بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. I'm Professor Eyad Gadour, I'm consultant gastroenterologist, hepatologist, and advanced endoscopist. It's my pleasure to be part of this great IGCC conference for the second time in Jeddah, Saudi Arabia. And today I have two pioneers speakers from Italy and from the States. So if you introduce yourself, Professor Antonio, please.
Thank you, Eyad. I'm Antonio Facciorusso, full professor of gastroenterology, University of Lecce, director of the gastroenterology unit in the hospital in Lecce. It's the second time for me to be not in Jeddah, but in Saudi Arabia. The last time was in April in Riyadh. It's always a pleasure for me to be here.
Thank you very much, Professor Haddad.
Assalamu alaikum wa rahmatullah. Dr. Mohammad Haddad. I'm professor of medicine and director of Division of Gastroenterology and Hepatology and advanced endoscopist at Indiana University School of Medicine. Also my second year on the IGCC. Pleasure to be on the organizing committee and witnesses substantial growth in faculty and scope of discussions and lectures and debates that are part of the second iteration of IGCC. Of course, I've been to Saudi many times, and it's like home to me. Thank you for the opportunity to be on this podcast.
Welcome, both of you. So hopefully we're going to be talking about two separate topics today. And we'll start by the first topic, which is suggested by Professor Haddad about building a new service or new program in gastroenterology. So, Prof. Haddad, you have experience, very good experience and knowledge with this kind of service and development. So, how would you start? I guess it's going to be idea first, funding, study, and this kind of thing. So, from your experience, how can we build up a center or new service or new program for gastroenterology?
Thank you, Dr. Eyad. I travel frequently around the globe, but specifically in the Middle East, I often get asked the question, I have an idea to start a new program. How do I bring the idea to life? And I think this is a great discussion to have, especially as we see an expansion and maybe even explosion in the technology, science, but also there's the population that needs to be served, especially with advanced endoscopy. I had the luxury and the privilege to have been part of starting programs in the region and in the States, so I can weigh in on the different angles you can have this discussion and what is involved in having a sustainable and robust clinical service. Obviously, the first you'd have to have the talent and the expertise, and there has to be a gap in the service that this new program will fill. Maybe in a new city, or maybe in an existing large city that requires a new dimension to be introduced. The most common of these we see these days is interventional endoscopy for even third space endoscopy or anti-reflux type of endoscopy or weight loss. I highlight these three programs which could be under one single umbrella because there is a huge demand for all of these at this point. And there's relative paucity of centers that provide comprehensive services to patients who require any of those. So what I have found helpful is to identify geographically where the area will be, your catchment population, who are you going to be serving with this program, and then come to existing hospital systems to discuss funding. Obviously, you can't do this on your own. You need the fund. You need a hospital to embrace and adopt this. You'll need the resources to build clinics, endoscopy suite, invest in technology, and also have a core of advanced and therapeutic endoscopists who could be your partners in this practice. I would say a minimum of 2 to 3 plus a director, obviously, to start the service. And once you have this up and running, you'll need to have your service line well built, referral base, obviously, reach out to all the providers and the gastroenterologists, surgeons, and primary care doctors in the area. Tell them what services you can provide, and also start with building simultaneously, and I think this is where you can weigh in very well, Antonio, on potentially building registries to catch all the great things you're doing, patient population, what services you are providing, what outcomes, quality outcomes, benchmarks, are you keeping up with everything from adenoma detection rate to curative resections to weight loss outcomes, you need to be able to come back in a year or 2 or 3 and tell everyone that your program actually is delivering back at the level of quality that it's supposed to be doing. Not just volume plus quality. And with that comes a tremendous opportunity for research. And this is where you start to build your registries and you provide education also along the way. So maybe a fellowship program might come as a third arm. It's always service, education, and research that bring a program to fruition. And no program will stand on 2 legs only. You need 3 of these components for a program to stand. So I would highlight all the above components of a very successful new program.
Okay, thank you very much, Dr. Haddad. From your point of view, Antonio, as researcher, and do you think right from the beginning, when you establish service or program, you would recruit researchers, you would recruit fellows, or you first have to establish it, make it up and running, and then consider adding the sugary part of it?
This is a timely question because I'm exactly in that situation, because now I recently moved to a new city. I am starting a new program in another university, so I'm in that situation. So we should recruit. The perfect situation will be to be able to recruit both researchers and very good, talented endoscopists. But this is not always feasible, not always possible. First, you should serve patients, of course. First, you should have data to do research. So if you have to choose, the first thing is, of course, to start the program with the endoscopy unit, performing procedures, training new mentees, new doctors. I was about research. I was always jealous of the huge amount of data that the Americans are able to gather. Also for the training program in Europe, we try to do the same, but the situation is not exactly the same. We had the problem, for example, when we did ESG, we tried to put the curricula about several procedures, and we had to rely on the American data because we don't have usually, except some exception, a tracking of the progress of the fellows. We don't use the validated tools to track the progress of the fellows. So this is a thing where we should improve, not only in Italy, but in most of countries of Europe. And this is important also for research.
Fair enough. And Dr. Haddad, you have experience in both building or establishing center in the States as well in the region. Were they just juxtaposing each other, or there were huge differences and the legitimacy about it? Can you tell us your experience?
Yeah, this is a great question, Dr. Eyad, and I think there are a lot of nuances that are kind of complicating the picture. One of the main differences I see is obviously who's paying for these services, and in the region there are, and in Europe as well, you see these government-based coverage services, which are to somewhat present in the U.S., but not the predominant model of payment. So to sustain a program, you make sure that you have the fund flow coming from, if you do an endoscopy, who's paying for it, how much are they paying for it, who's paying for the supplies and equipment. So that's a very important component of the program, is understanding the fund flow, talking to the various stakeholders, whether they are hospital administration, government-sponsored insurance, or private insurance, which I think will be the main components of any program, and making sure that you have contracts with them that are fair and equitable and transparent, so you can get the fund flow coming. So I see that's one of the major obstacles to especially in advanced endoscopy. We do a lot of very niche type of procedures that don't necessarily come with a good payment. Okay. So you're doing a 2-hour third space endoscopy, and you're ultimately getting paid for a diagnostic EGD or diagnostic upper endoscopy, which is unfair. So there's a lot of nuances to that. You want to make sure that you get paid for what you provide. So that's one component. The other part is finding expertise and talent for the program, whether it's at the endoscopist level or at the nursing level, and getting some support from the institution for things like research infrastructure. infrastructure, coordinators and registries to be able to be successful. And that's, I think, still emerging in the region. I wouldn't say it's completely lacking, but it's still emerging. But you have to focus on professional development of your staff, making sure that you also recruit very talented and capable endoscopists. And you come to courses like this one, for example, where you can get, widen your network and you get to know what other people are doing, what is the best practice in the region, because what might work here may not work elsewhere. We heard this morning, Barrett's management may be different in the region compared to the West. So you have to embrace these differences and these nuances and customize what you deliver to what is best for the region. But there are definitely challenges, not unsurmountable in my opinion. However, you would need to be persistent and resilient in providing a service first, and next education and research as the following components.
Thank you. And Antonio, from your experience building or establishing service, can you start by providing super specialized services straight on, or it has to be basic service you develop and you provide, and then you build on that?
Now you should do both at the same time, because patients need also super specialized service, not just the basic endoscopy. So it's not acceptable anymore to have just basic endoscopy and then in the future we see if we can do something more. It's not acceptable anymore, at least in a referral center, of course. I would add a comment about the training in research. Training in research it should be parallel to the training in endoscopy. It requires a specific training. This is why all the major societies, I know the American societies with ESG, we are doing some research camps. For example, in February in Munich, in Germany, we will have the research camp about ESG, is the second edition. It's important not only to learn how to do research, but to build the network. This is what I did in my career. It was a specific need for me because I work in a very small center. I didn't have people around me doing research in my field. So I had to write to people, to ask to do research. I learned from them. And this is why in a time span of 10 years, I built a strong research network. This is what people should do, particularly if they are interested in research, and they don't work in a high volume center where there is a big university where there are a lot of researchers. So research is feasible, wherever you are is feasible, but you should have the chance to do it. And you should build a network for that.
Fair enough. And Dr. Mohammed, you're doing lots of research in your center and lots of publications in your center. As Antonio mentioned, I think networking. So do you have established a collaboration between your center and other centers in the States and other centers outside the States? And what's your view on that?
Yes, in fact, we do have collaborations from within the US and even globally, including Europe and the Middle East, mainly as two partners outside the US. I see the value in these collaborations because mostly, especially if you're looking at a super specialized type of endoscopy, no one center will have enough volume to promote a best practice or even set the benchmark on a quality. You have to look at outcomes collectively from centers of expertise and be able to describe the outcomes of a large cohort. And that typically requires 5, 10, 15, maybe 20 centers to pool their resources and their data and look at the outcomes. And quite honestly, this is what we do with guideline development. For example, we're very familiar. We run these large meta-analysis. You're an expert as well, Dr. Eyad, on meta-analysis. You've been part of a lot of guidelines as well, Antonio. And it's hard to do that if you have very small case series here and there. You really need the volume and you need also the length of time to study the outcomes, not just 1 or 2 or 3 years. You need 10 years, 20 years worth of outcomes from many centers to be able to do that. So collaboration, especially in endoscopy, we do very niche things that maybe centers may have the chance to do a few cases a year here and there, not enough to be able to describe what a best practice and best outcome could look like and set the benchmark on that. So collaborations are essential. And I think it's any center that does advanced endoscopy will need the resources to be able to capture their outcomes, in a database or a registry. And often it's either fellows or residents helping, or maybe coordinators who can help. But I agree with you, Antonio. This is an essential part, and that should start in parallel with the clinical service, not lag behind by 5 or 10 years like we see in some places. I cannot emphasize how important this is for any program, especially advanced endoscopy program.
Me and Antonio and I yesterday we were talking about the AI and meta-analysis and a systematic review. So what do you think about the future of meta-analysis, systematic review, and in the era of AI? There are lots of AI programs now. They can help in writing systematic reviews, and many journals now they have AI editors. Good journal, key 1 impact factor above 5, they have AI editors. And I've seen lots of programs from the States done by physicians, pioneer physicians, and they recommend using their AI in order to help in writing and generating reliable data. So what do you think the future of systematic review and meta-analysis?
I will stress the concept on the last word you say, the reliability. This is the issue. Because, okay, we have a lot of tools now, but are they really reliable? Are they really validated? At the moment, we still need more experience with that. So honestly, now at the moment, I don't see a role now, sure in the future, but now I think it's too premature, too early. About the use of AI, as in all the other fields, the problem is that the situation could be out of control. So here we have the editor of an important journal, so he can say better. The journals are very careful about the use of AI. It should be declared in certain situations. So we should be very careful. It's an opportunity, but it could be also a risk. So it's a challenging situation, and we should be able to use. In the specific situation of meta-analysis, okay, but in the guideline, we still, at least in the European society, we still are reluctant to rely on.
So you think meta-analysis with the AI would be reliable?
The issue is not the statistical approach. It can be done with AI, but also with the tools that we use, are the other state, all the other programs. The issue is the literature search. Are we sure that the literature search is comprehensive? All the relevant studies are included. And the non-relevant studies that are initially screened, are they excluded later? About that, we still need validated tool. This is the issue in the meta-analysis, not the statistics. The statistics, okay, you can do it, but also with many other tools that we have for long years. The problem is the literature search.
Dr. Haddad, as an editor, what's your take on AI?
It's funny, Dr. Eyad, you and I had this conversation. Actually, the three of us talked about that last night over dinner. And I think the AI wave has already taken on. I don't think that you can contain it anymore. So whether we like it or not, people are going to use it. Journals are going to have to see it, and authors will have to contemplate how they use it. My issue is the lack of overall guidance and regulation from the government side, for example. How do you regulate AI? To start with, there's not much of any guidance there. As we work through the journal I represent, we do require declaration of use of AI. It is not something that will disqualify the paper. However, we would like to know if it was used and in what capacity it was used as you generate your manuscript. If you tell me it was used to refine the language, for example, we have a lot of submissions from non-English speaking countries, and the use of AI I think is very appropriate to make sure that the text and the language is appropriate. In the analysis, as long as there's some vetting process, I think it's reasonable too to utilize that. As long as you tell me what components of the paper were used for AI, I'm not going to disqualify that paper. Obviously, we'll put the paper to a rigorous review and vetting by experts to make sure that everything aligns. However, I don't think that we can completely disqualify or say that if you use AI, you're not going to be able to submit and publish at this journal. I think it's an unfair statement, and honestly, I don't think that any journal that will not embrace the wave of AI is going to survive in the near future. I just wish we had a little bit more guidance and regulation from the authority level and the societies. I know some societies are now working to establish some framework on how to adapt and use AI in medical publishing and scientific vetting. And I think we'll see a little bit more of that. But you're right, it's a very fast moving field and regulation is far behind.
And the last comment I would like from you is about like Antonio and his colleagues are leading research camp as part of the ESGE. And so in the States, do you have such research camps, research opportunity apart from the routine research fellow or MD or PhD?
So I have to give credit to our European colleagues, and you and I have this conversation before, Antonio, about it seems like you have definitely more pathways and structures to produce physician scientists, endoscopist scientists who are capable of not just providing a very high quality endoscopy, but also publishing and writing and performing high quality research. Unfortunately, in the US, there's no uniform pathway or guideline. I know in Europe and in the region, the MD PhD pathway is a common one for someone to come through and become a sort of a physician scientist. It's not as clear in the US on how you would do that. Most of those who do this work have come through traditional MD pathways, and they have developed interest in research and maybe have obtained a master's in science and research methodology on the side, but not necessarily those who have done an extensive amount of work to prepare themselves to be researchers. So it is less established. I sometimes look up to our colleagues from Europe to maybe show us how you can effectively do that. The model is just completely different in the US. Unfortunately, the funding is not as available from institutions and from the government to promote these pathways of research endoscopists, if you will. So I would say to a large extent, it's work in progress right now.
Thank you. And last comment from you, Antonio, about the research camp, importance of research fellowship, for example, and networking in research.
Yes, I think it's a good option because, okay, now with the email, with the video calls, we can do whatever we want, but the physical interaction, of course, is still important to exchange ideas. Okay, I have a good idea, but I don't know how to develop it. This is a common issue at the beginning of the career because, okay, one talented youngster can have good ideas, but how to develop, how to draft a protocol. Should I do a randomized trial? Should I set up a registry, a database? How to do it? So which mistakes not to do? So and also to be familiar with what the editors want, no? Because also this is an important situation, how to convince the editor, for example, to send out the paper to reviewers. And these are things that you can learn with experience and benefit from the experience of people that are in this world for a long time. I think it could be useful. With the ESG, this is the second edition. The credit should be to Professor Lorenzo Fuccio, that was the mind behind the research camp. And also about the documents produced by the society. I don't know, in the American society, now we are very careful in this ESG. We set up a publication working group where I co-chair. The leader is Professor Michael Brettauer, a very important researcher, and also a methodology task force. So all the documents produced by the ESG should be methodological sound, they should represent a good science. It's not enough to gather the experts that, okay, they do wonderful procedures, but just there is an expert opinion. Now, what we want is something different.
Thank you very much, Antonio, and thank you very much, Mohammad Haddad, for your time and your valuable input. I think by this we conclude our meeting for now. Thank you very much.
Thank you.